everybody. My first video will be talking about the gait cycle, common gait deviations that I see as a neuroclinician or that you orthotherapists see, and then some intervention ideas in order to figure out a way to help them train their way out of it, work on stability, range of motion, what to look for, how to address it. So stay tuned. So we've all heard of this gait cycle. There's two phases, stance phase and swing phase. We spend a majority of the time in that stance phase, about 60%. There's different phases that I'll continue talking about, and then we'll go into gait deviations. And in my next video, we'll talk about, and I'll show you the interventions that we will use in order to address these common gait deviations. So we start with initial contact. Your leg is getting through, your heel striking on that floor, and then you perform hip extension in order to get your center of mass over that base of support, which we call our loading response. In order to achieve this initial contact to loading response, we need hip stability, knee control, and ankle plantar flexion. So you need about 0 to 5 degrees of that plantar flexion in order to get that heel down in order to advance that limb over your foot. You need about 20 degrees of hip flexion to make that initial contact, and then your knee will bend a little bit once you've hit that foot flat range. Mid stance to terminal stance, the tibia advances over the foot. In order to do that, we need some ankle dorsiflexion up to 10 degrees, 0 degrees of knee extension, and 20 degrees of hip extension. For pre-swing to initial swing, we need 15 degrees for that push-off. You need 60 degrees of knee flexion in order to unlock that knee, and then you need 15 degrees of hip flexion to get it through without stubbing your toe or dragging your foot. The last cycle is that mid-swing to terminal swing. This is when you need increased hip flexion and ankle dorsiflexion, and you need to extend that knee in order to prepare for an initial contact. You need about 90 degrees for neutral dorsiflexion, 25 degrees of knee flexion to 0 degrees, and then 20 degrees of hip flexion. Common gait deviations that I see as a clinician, first of all, is Trendelenburg gait. We don't have that hip stability on that stance limb, which causes the contralateral hip to drop. I see this a lot in people who have just general hip weakness. They've had some knee pain, hip pain, back pain, even chronic low back pain has been shown to have reduced strength in those hip stabilizers. Another common deviation I see is crouch gait, and whatever it may be, just general posterior weakness, anterior tightness that we see a lot, especially in people who have Parkinson's and just general the older adult population where they're just gravity's pulling them down. Another common gait deviation that I see is the WADDLE or bilateral Trendelenburg, where people come in, they're like, why do I waddle? I've noticed that I do this. And it's from overutilizing those lateral flexors of the spine rather than using the hip stabilizers and glutes, everything like that, where they kind of lateral lean over that stance limb rather than fully weight shifting over and using those hip muscles. They want to avoid it, so then they get weaker, so then they can't use them, so then it makes it worse. Another thing I see a lot, especially in CVA, spinal cord injury, is extensor thrust, where as soon as they hit that mid-stance, their knee hyperextends. This could be due to weakness in the calves. That's not controlling that tibial progression. It kind of just shoots back. It could be from quadricep weakness or hamstring weakness. So I'll touch a little bit more on that in a little bit, on what to look for, how to check each one, and then intervention ideas. Toe walking is pretty common in like the kiddos. We'll see where they have tight calves, strong calves, weak dorsiflexors, hip weakness, glute weakness. They're just utilizing those calves to get around. Scissor gait is super common in spinal cord injury, CVA, or meningitis. So people have spasticity in the quadriceps, which causes it to kick in. They go into that extensor synergy, which is the knee extension, hip adduction, and internal rotation. And at the level of the ankle, they do plantar flexion inversion. So we call it narrowing of the base of support, where they're just kind of crossing over themselves, which leads to a lateral loss of balance. They also have a lot of weakness in those hip stabilizers. Vaulting is super common in people who've had a CVA. A lot of times when people wear an AFO, they don't have the option to do that plantar flexion heel off and that terminal stance to initiate swing phase. So what they have to do is on their non-paretic side, they have to do a little hip hike, they have to use their QLs, they have to use, sometimes they go up on their toes, they use those calf muscles, swing that leg through because they don't have enough strength in their hip flexors, hamstrings, dorsiflexors in order to do a normalized gait pattern. This is why I never do a straight leg raise with anyone who's had a CVA, because it teaches them to be quadricep dominant, teaches them not to bend their knee, and then they have to use their quadriceps. They use that spasticity, they feed into that in order to do bend mobility, walking. It feeds into that vaulting. So in my part 2 of this video, I'll be showing you guys some different intervention ideas, how to make it harder, how to make it easier, and most importantly, how to make it functional, because that's the idea. We're training all these things in order to walk better, be safer with transfers, reduce the caregiver burden of, min to mod to even max assist, and trying to get people to do as much as they can, just to improve their overall independence and quality of life. So stay tuned for my next video, and we'll go through some of those. Thanks.